So I want to welcome everybody to this week's Grand Rounds for Family Medicine. For those of you who are interested in CME activity credits, you'll want to make sure that you do claim your credit before midnight tonight. The activity code is listed here for you. And I will go into some more details in the next slide, but just make sure that you do register for credit before midnight tonight. So we can take a look at the next slide here. So for those who have not yet registered, please make sure that you do so by sending your email address to the toll-free number listed there. After you've done that, from that point forward, you just need to send in the activity code for the day, along with the word attend. So for today, you would text attend and then the code that you see listed there. Again, I'll put that information in the chat box here shortly, but that is how you would register for your CME credit should you be interested. Next slide. So as we go ahead and get started here, just want to take a moment to remind everybody, if you have not, make sure that your microphone is muted. Also, if you could be attentive and engaged in the session. I know that our presenters have mentioned that they're going to keep an eye on the chat box with me, but if you have questions, please go ahead and put those there. And then I will also be updating the chat box towards the end with the link to provide feedback. Next slide. So just as a reminder, we are partnered with the South Central AHEC. And our mission statement is there for you to read if you're interested. Next slide. For those claiming CME, if you are having any issues with your CME, or if you need to view your transcript from time to time, please just feel free to visit the CME office website. It's shown there, but you're also more than welcome to reach out to me as well. You will need that CME transcript as we go on to the next slide here. You do need that if you are going to be claiming credit through the AAFP. So members who are doing that, just keep that in mind. The AAFP information is listed there, but again, if you have questions, please feel free to reach out to me as well. Next slide. We also want to make sure that we do mention that it is the goal of our FCM Grand Rounds to address these nationally established physician core competencies that you see listed here. Next slide. And we also want to make sure that you are aware that our presenters have no relevant financial relationships with ineligible companies to disclose. And so I'm going to be introducing to you, we have Dr. Sarah Oberhelman-Eaton, we have Dr. Natalie Erbs, and we have Dr. Colt Sanama, who are going to present to us today on pregnancy and postpartum care for transgender, non-binary, and intersex people. So I'll let them get started.
Thank you so much, Nicole, and thank you all for having us today. We are so excited to be here appropriately on the first day of Pride Month to talk to you about a topic that is near and dear to our hearts, which is sensitive care in the pregnancy and postpartum time period for transgender, non-binary, and intersex people. As Nicole mentioned, I'm Dr. Sarah Oberhelman-Eaton. I practice full spectrum family medicine at Mayo Clinic, including full spectrum obstetrics and delivery care. And I have a special interest in lactation and provide complex medical lactation consults for the enterprise, including for our transgender clinic. Dr. Erbs is also a full spectrum family medicine provider, in fact, delivering one of our babies overnight for our department, and yet here with us today. And Dr. Sanama is a second-year resident in our department. He provides a wealth of information regarding sensitive care to transgender, non-binary, and intersex people, and also is a psychologist with the University of Houston and Baylor. So we are all excited to be here today. Our objectives today, first, we're going to define gender-related terminology so that we are all on the same page. And then we will discuss the impact of gendered language on patient care, specifically in the obstetrical and postpartum worlds. We'll then learn about the unique healthcare needs of transgender and intersex patients, especially in the obstetrical and postpartum world. And finally, talk about how families with gender diverse parents may choose to feed their infants. So why does this matter? Unfortunately, transgender, non-binary, and intersex people often receive poorer medical care. Why is this? Well, first of all, we as physicians are often poorly trained and poorly equipped to provide excellent care to these individuals. Second, oftentimes these individuals have been the victim of microaggressions when receiving their health care, and this can lead to many of them not seeking health care as regularly as would be ideal. We as family physicians don't care for one gender or one age or one body part or one life event. As you know, we care for people over the entire longitudinal spectrum of life. And as that, we believe that we are at the forefronts of bridging these health disparities. And finally, all people deserve access to safe, compassionate, and empowering pregnancy and postpartum care. And we wish to help empower you to deliver that. So with that, I will turn this over to Colt to talk a bit about language.
Hi, thank you all so much for having me. As Dr. Oberhelman-Eaton has said, I am a licensed psychologist in Texas, actually, born and raised there, and I'm a family medicine resident physician, almost a third year. I'm also openly transgender myself and began my transition in 2007. I'm planning to return to Houston after graduation year, so maybe we'll be collaborating with many of y'all. So language really is a foundational component in becoming comfortable with providing care to trans and intersex people. Here I'm going to review a few definitions, but I really encourage folks to learn what the terms mean for your individual patients, as two patients may use the same word to describe their experience, but may have different definitions for that exact same word. And this is really especially critical to talk about language in the pregnancy, birth, and postpartum world, which is incredibly gendered. So here's the definitions we're going to talk about today. First, let's talk a little bit about sex versus gender. As you know, these are typically used interchangeably in everyday life. If you were filling out a form and it said sex blank or gender blank, most people would put the exact same answer there and not even think much about it. An easy way for me to think about the difference between sex and gender is to think that sex is what other people told you that you were when you were growing up, and gender is what you say that you are. Sex is typically assigned based on appearance of external genitalia at birth, but sex actually, as we know, includes multiple components in addition to external genitalia, including your sex chromosomes, relative levels of sex hormones, gonads, as well as internal genitalia. All right, in terms of, many of you may have seen, or some of you may not have seen this acronym AFAB, AFAB, or AMAB, as we call it in community. This stands for assigned female at birth or assigned male at birth. And people are beginning to use this terminology more even in their notes. So we wanted you to be familiar with this terminology. Transgender, anyone whose gender is different from their assigned sex. So who they know themselves to be is different than who they were told they were gender-wise. So I am transgender and I was told that I was a girl, but I know for sure that I am not a girl. My gender is not so simple as, oh, well, if you're not a girl, then you're a boy. It's not so simple for me, but because it's not a girl, my gender is different than my sex, so I'm transgender. Transmasculine, transfeminine may be used as an attempt to be more inclusive of folks that have both binary or non-binary gender identities. So transmasculine would be a spectrum of folks that I would be part of because I'm AFAB or assigned female at birth, but do gender more masculinely than to be expected. And somebody who's transfeminine typically will be assigned male at birth and do gender a little bit more feminine or a lot more feminine than was expected. All right. I think it's important to also talk about intersex people can also be trans. So an intersex person who was raised as a girl but says, ooh, that's incorrect, may also identify as transgender if they make a gender transition. So they might be transmasculine, transfeminine, as well as intersex. Non-binary, that's a gender identity that's neither exclusively man nor exclusively woman, which are considered binary or two options, man and woman terms. So non-binary outside of just a boy, just a girl. Intersex is what I learned in medical school to be a variation in sex characteristics, like we talked about before: chromosomes, sex hormones, internal genitalia, external genitalia. They use the word disorder of sexual differentiation, or DSDs. Remember Turner's, Klinefelter's, CAH, AIS, androgen insensitivity syndrome, etc. And there are hundreds of intersex conditions. Gender diverse can be used as an inclusive term of transgender folks as well as gender nonconforming people, which would be masculine women, feminine men who may not identify with the term transgender, and some non-binary people don't identify as transgender, and so gender diverse can be a way to include them as well. And then gender dysphoria, there are actually two different ways I think about this term. One is the lowercase gender dysphoria, one is the uppercase gender dysphoria. Lowercase gender dysphoria is the personal experience of something's just not quite right with somebody's experience of their gender or their body or both. And the uppercase gender dysphoria is the DSM or the psychiatric diagnosis. Next slide, please. This is for Dr. Erbs.
All right. Hi, everyone. So I'm staffing our newborn nursery this week, as well as covering our resident deliveries. So I've spent a lot of time at our birth center these last few days. I want you guys just to take a moment to think about, what do patients see, hear, what do they experience as part of their OB care from their first prenatal appointment all the way up until when they leave the hospital with their child? And what would someone who is transgender, non-binary, or intersex make them feel unwelcome, make them feel isolated, make them feel like they're not supposed to be here? So what do patients see? We think of, like, what do our waiting rooms look like? What are our patient handouts look like? What do the pictures on the wall look like? How are things styled in labor and delivery? When we think about books that we give out, they're all about pregnancy, and they'll have a pregnant woman on there. We talk about lactation. We talk about parenting books. When you think about pregnancy and postpartum clothing, it's maternity bras, maternity clothes. Even prenatal and birth classes are very specific for heterosexual couples. And shopping for baby items, I know we see a lot of very gendered pink versus blue items that people want to buy and think, well, I need to know what my child is going to be so that I can buy the right clothes, in quotations. And then what do patients hear? We always talk about women's health and mother baby unit. We have mother baby rounds, maternal fetal medicine. We talk about maternity care, advanced maternal age, breastfeeding, breast milk, a breast pump, a vaginal delivery, vaginal exam. We a lot of times will refer to parents as, mom, dad. Is this going to be a boy? Is this going to be a girl? And my all-time personal least favorite is the dreaded gender reveal party that people always talk about having. And I always try to remind my pregnant patients that really you're having a sex chromosome reveal party, if that's what you did it, or a genital reveal party, and that your child's really going to decide later on what gender they would like to be. I think it's also important that legal matters matter. For transgender individuals, we have to look at, even filling out a birth certificate can be very triggering. In Minnesota, where we practice at Mayo Clinic, our birth certificates will list parent 1 and parent 2 for those that are married. If there's non-married parents, they have to use a certain form to get the other parent, biological parent, on the birth certificate. And a non-biological parent has to adopt. So for instance, if you had 2 women that identified as female and only one was the birth parent, whereas the other one is also still going to be a parent, they might have to adopt. In Minnesota, though, the baby's sex can be listed as unknown or X. And that is the one difference that we saw in Texas. Your birth certificates also show parent 1 and parent 2, but the baby's birth certificate must list the genital sex. So this is what we do in the nursery every day. A baby's born and we say, oh, baby has a penis, so that's a boy. So that would be on the birth certificate.
All right, so now let's go into discussing pregnancy care for this population. Let's first talk about testosterone, because many of the patients in this population may have taken testosterone or may actually be taking testosterone when they realize that they are pregnant. So some of your patients will have been on testosterone, others not. We do know that testosterone is not a contraceptive, and some patients may be taking testosterone just prior to and during pregnancy, especially if they did not realize that they were pregnant. We do recommend discontinuing testosterone during pregnancy, as well as when people are trying to get pregnant so they can ovulate. But especially during that first trimester when fetal genital differentiation and the urogenital sinus is differentiating during that first trimester. However, we also recognize there are important mental health benefits that are associated with testosterone treatment in this population. That's what I did my dissertation on. And all we have to rely on in terms of data to inform the recommendation to discontinue testosterone is rat models. And in rat models, they did find that testosterone was teratogenic. Of course, how much did they give? There's all sorts of questions, but we have no longitudinal human studies with testosterone use during pregnancy. Next slide. Sensitive exams are really going to be a foundational component to providing good care for this population. It'll be important to use a trauma-informed care model. And if that's not something you've read about yet, highly recommend it, specifically because many trans and intersex patients have had previous negative healthcare experiences. Some have had traumatic experiences specifically involving their genitals, whether within or without or outside of medical care. And some also have genital dysphoria, or maybe a combination of all three of those. And so it's really important to be aware of that when approaching these patients and their bodies. So if there's ever an alternative option to a more invasive exam, we recommend offering all of the options and allowing the patient to choose. Trauma-informed care really helps patients to be more in control of what happens to their body. So offering options and allowing them to choose is one of those. So for swabs, if at all possible, consider self-collection. Also minimize the number of pelvic exams. If a patient prefers not to do a transvaginal ultrasound, see if you can try transabdominal. If you still recommend transvaginal after transabdominal for a better view, explain that to the patient and see if they will consent. Also, you can ask them if there's anything to make that you could do or not do or say or not say to make that exam more tolerable. Gender dysphoria in and of itself may be exacerbated during pregnancy, both socially as well as physically. Socially, as Dr. Erbs already talked about, there are many messages that a pregnant person is a woman and therefore will be a mother. Both of those may not fit with these patients' experiences and can be invalidating over and over and over again on a daily basis. Clothing may be challenging to figure out, especially if they've had a mastectomy and don't have breasts to fill in, or especially if they don't have a penchant for floral clothing or pink. Physically, they may experience dysphoria related to further breast growth or being perceived as a woman as well. So things to check in with in your patients and provide a safe space for them to talk about these issues. Social support may not be guaranteed from parents, family members who may not support the trans person on the basis of being trans, on the basis of being pregnant, or both. I do recommend on checking in on sources of support in general, as well as sources of support or not support, rejection from families of origin, as well as chosen family or families of choice with these patients. As Dr. Erbs mentioned, birth classes patients may not have access to these or may not feel as welcome in birth classes, which can be very gendered as well as heteronormative in their language. And then in terms of language with your patient, do check in and learn what words the patient uses for their own anatomy. Breasts, vulva, vagina, are those their terms? Some people are like, whatever you use with everybody else, I don't care, let's move on. And others will like, don't call me that, call it front hole. And so work with your patient and go with what they say. Also, do learn about what the patient prefers about how they learn about the genitalia of their fetus or baby, as well as the distribution of that information, who gets to know and why. For some trans people, being assigned a sex at birth was their original traumatic experience. So therefore, this should be handled sensitively. Next slide. For birth care, again, with sensitive exams during birth, we have cervical checks. We have a lot of different people coming in and out of rooms. And so for those doing prenatal care, make sure to set up people with the expectations of what happens in that particular area. If there are things you can do to minimize a person's traumatic experience, like having the same folks over and over again, if possible, work with your team, see what you can do, and make sure the patient knows what to expect. Language, you see this all over the place here. So it'll be important to increase your own awareness of what kind of standard terminology you have in your own space, such as maternal, ladies, moms, whatever the general language is used, and try to use more inclusive terminology and model that for your colleagues. So things like maternal heart rate using parental heart rate or child bearer heart rate. Learn about the childbearer's preferred terminology. I love the word childbearer. I think it's super empowering and gender inclusive. Some people might not love that. So check in on what term they want to be called. If they are planning to parent the child that they deliver, what term are they wanting to use for being a parent? Is it Baba, Daddy? What is it? And make sure to communicate this language with the entire team to minimize experience of being misgendered, because it's an all too common negative experience. And really that can help set your team up to create positive patient experiences. And lastly, here, the route of delivery. We don't have a lot of data on this, but we do know that there was one study that found that 25% of C-sections in this population were elective. A C-section may be preferable to some of these patients due to genital dysphoria, or having a vagina that is less than optimal for delivery due to surgery or an intersex variation. Next. Dr. Erbs.
All right, I'm now going to talk about postpartum care as well as the nursery care. So these are pictures that I actually took over the weekend in our nursery. So at least in our institution, the baby name would be either baby boy Smith or baby girl Smith. We don't have a just generic baby Smith. We have these pink and blue cards that you can see here, very clearly saying it's a girl, it's a boy. We make these baby hats with bows right away, and we have door signs that will say boy or girl. I would just want you guys to kind of reflect what are areas that you might have in your hospital that are very gendered. I do appreciate we only use these hats momentarily. We have a lot of volunteers that knit hats that are just all very generic, and I tend to like those hats better. Next slide. As far as the patients themselves and the childbearer themselves, these patients may be at risk of postpartum depression. Again, they may have continued gender dysphoria, especially as it may relate to their testosterone or planning on chest feeding. It's also important, this is a good time to talk about contraception, because we know that the unplanned pregnancy rate in the gender diverse population is estimated to be the same as the general population. And reminding patients that even if they go back on their testosterone, which may cause amenorrhea, that doesn't necessarily mean that they're not ovulating and therefore they can get pregnant again. And also think about what the impact will be on their masculization process. Giving these patients an estrogen containing contraceptive is probably not an ideal situation by any means. There may be some impact on their menses, and so you do want to talk to patients about this. And then also thinking about the timing of when are they going to restart their testosterone therapy, and that might be affected by their plans for lactation. And with that, I'm going to let Dr. Oberhelman-Eaton take over, as this is her area of expertise.
Thank you, Dr. Erbs. So I'm going to spend the next few minutes talking about lactation in the gender diverse population. And the two main messages that I wish you to take away over the next few minutes is, number one, people with mammary tissue can lactate. And number two, our goal as healthcare providers should be to help our patients meet their safe parenting goals. So I'm not going to turn you all into experts on the nuance of induced lactation protocols and pluses and minuses of testosterone therapy in the immediate postpartum time period, but I do want you to be thinking about this and recognize that there are a lot of options you may have not previously considered. And while these need to be talked about long before the patient reaches the hospital and supported long after they go home, the care that they receive in that initial postpartum time period in the hospital is going to be absolute key to feeling supported as new parents. Why are we talking about this? So human milk is the ideal form of infant nutrition. Studies have shown that infants consuming human milk have lower risks of infection, lower incidence of SIDS, lower incidence of some cancers, lower incidence of obesity, not just in childhood, but lifelong. Additionally, human milk is not going to be impacted by national formula shortages. If a family chooses to utilize human milk, we absolutely need to find ways to support it. Language, once again, is important when we're thinking about lactation as well. The term breast can be triggering to many individuals, whether it's being used as an anatomic descriptor or in terms of breastfeeding, breast milk, breast pump. We use the term breast a lot in the postpartum world. Some individuals may prefer the term chest feeding, while others may prefer a more gender neutral term such as nursing or a more clinical term such as lactation. The only way to know what is best for the patient in front of you is to ask them and to use their lead to use the correct language for that family. So infants need to eat, and they can eat one of three things. One is human milk produced by their parent. They can eat human milk that is produced by someone else and donated to that individual, or they can eat formula or a combination thereof. The way that milk gets into the baby can also be varied. If it's coming from a parent's body, it can come either from the parent who is making the milk, or if that parent is unable to make milk for a variety of reasons, they can still latch the child onto their body and feed milk from another source via an SNS, which is a supplemental nursing system. And I'll talk more about that in a few minutes. Alternatively, if not feeding the milk from the body, we can use an artificial nipple via a bottle or a non-nipple form such as a syringe, cup, spoon, or finger. So first, transmasculine individuals can lactate. So if the patient in front of us is the gestational carrier, whether or not that individual wants to continue lactating, lactogenesis will physiologically occur. So it's important to think about this ahead of time and determine what does that patient want. Can we support this individual in ongoing lactation, or can we support this individual in attempting to suppress ongoing lactogenesis and lactation? We've talked a bit about gender dysphoria. Lactation may worsen, it may help, or it may be neutral for gender dysphoria in a given individual. For some people, the mammary growth, the societal implications of feeding a child in public can really worsen the gender dysphoria that they're experiencing. Several case reports have shown that for some individuals, gender dysphoria actually improves as the mammary tissue is used for its anatomic purpose as opposed to a sexualization. And during this time period, there's actually less gender dysphoria. And so it's just important to recognize this and talk about it ahead of time in terms of what a person might experience. Chest binding is something that is often done by transmasculine individuals who have mammary tissue, but in the lactating world, I highly recommend against it, especially in the early postpartum course. And the reason for that is if the ducts in the mammary tissue are obstructed, this can lead to not only pain, but plugged ducts and mastitis, which can be a serious condition and one that we wish to avoid. It's important to recognize that prior chest surgery may impact the success of lactation. If the ducts were fully severed during a prior surgery, that will make successful lactogenesis impossible. However, many of these surgeries do not lead to complete severing of these ducts, in which case supply may be impacted, sensation may be impacted, but it would not be a contraindication to an attempt at lactation. And then finally, testosterone. This has historically been a very poorly studied area of healthcare, and it was a black box warning medication because we just don't know if testosterone has implications for the infant during lactation. There have been a couple of studies with testosterone use in cisgender individuals at low doses. And more recently, our group was able to publish a case report of a transmasculine individual who initiated testosterone therapy when his infant was about 15 months of age. And what we found is the testosterone does cross into the milk supply, but that the infant did not have any elevation in serum testosterone levels and had no evidence of masculinization or growth impairment. This really isn't surprising because testosterone is very poorly absorbed by the GI tract. That's why when we are administering testosterone therapy, we give it by injection or transdermal application. So far, we don't have enough evidence to make large claims, but these are the first steps in providing evidence that we may be able to better support our gender diverse patients' gender-specific medication needs during the postpartum period of time. So trans feminine individuals can also lactate. So these individuals would not be the gestational carrier, but may wish to participate in the lactation or feeding process. So induced lactation would be one option. In cisgender individuals, inducing lactation is often accomplished by the Newman-Goldfarb protocol. This does need to be altered slightly for a trans feminine individual because we will need to use estrogen and progesterone support prior to initiating the protocol. Essentially, what this induction process entails is using estrogen and progesterone to mimic the hormonal stage levels of pregnancy, then removing those high levels of estrogen the way would occur during a delivery, and utilizing either domperidone or metoclopramide, both of which are dopamine antagonists that work by increasing prolactin levels. I do want to mention that domperidone does have a black box warning and is not FDA approved for use in the United States. But it is commonly used in Canada. And then pumping and manual expression need to occur in order to stimulate nipple activity, as well as removing milk from the mammary tissue in order to support ongoing lactogenesis. Now, in trans feminine individuals who don't wish to go through the induced lactation process, or it's not possible, those individuals still can feed the baby from their body utilizing an SNS or doing non-nutritive suckling, i.e. would latch the baby to their nipple even though they're not producing milk. So I've made reference to the SNS a few times. This is what one looks like. Essentially, you have a reservoir in which milk can go, and that can be previously expressed milk, donor milk, formula. And then the tubing is attached to the parent's body. Oftentimes the tubing is taped to the chest or breast, and then the infant latches onto the nipple and is able to receive milk while suckling at the non-lactating or under-lactating tissue. In the small infants, you may use a syringe to better direct the milk flow. And you don't necessarily have to even use the chest or breast tissue. This individual has the reservoir attached to his sweatshirt, and you can see that the baby is latched to the adult's finger with the tubing present there. And finally, I want to mention that cisgender women can lactate as well. And the reason this pertains to today's talk is that I'm talking about families, and you may have a family with a transgender individual and a cisgender individual. And one of them may be the gestational carrier, they may be adopting, one or both of them may want to lactate or participate in infant feeding. And I just want to stress that this is a viable option for some families, but it needs to be thought about ahead of time. In these situations, if the cisgender woman is not the gestational carrier, induced lactation may be possible. If this individual does not wish to undergo the induced lactation process, the baby can still feed from the body, either with non-nutritive suckling or via an SNS. And it is important to think about, especially if you have two parents that are going to participate in the feeding process, to be able to think about how do we support supply, especially in those early days? How do we schedule feedings so that neither individual is being put at risk of plugged ducts? How do we make sure there is ample supply for both individuals and the infant is getting adequate nutrition? So good things to think about both before birth as well as after. So the key points here is that desiring parents can lactate and or feed the babies at their body, and we just have to be aware of the options and support parents in their goals. And our role as members of the healthcare team is to provide these families support in reaching these goals. We need to do so in ways that are patient-centered and hopefully start long before they reach the hospital. In fact, ideally long before they're considering pregnancy, hopefully even before they're having any chest contouring surgeries. And finally, more research is needed regarding gender-affirming testosterone therapy during lactation, as well as induced lactation protocols. back to Dr. Erbs.
Okay, so now that you guys have heard kind of some of the different areas, both prenatal, during pregnancy, postpartum, and part of the lactation process, I want you guys to think about what areas in your practices can you change to be more inclusive to gender diverse individuals. And these might just be on a small scale and not necessarily on a big scale yet. As I mentioned earlier, I have a lot of my OB patients talking to me about gender reveal parties and just reminding them that you're finding out either if you're doing a DNA test, you're finding out the baby's sex chromosomes, or if you're finding out through ultrasound, it's really just finding out the baby's genitals, and to think about that your child will decide later on. Those small, tiny changes can add up. And in summary, I think you've gotten across from us that language is so important, finding out what language patients want to use, what language they don't want us to use. And that pregnancy-related care for gender diverse individuals involves paying attention to language, affirming their gender, and also being sensitive to what they're going through. Knowing that gender diverse individuals can lactate and feed their baby at their breast or chest, whichever word that they desire to use, and how important our entire healthcare team is in providing gender affirming care using sensitive languages and sensitive practices for our families. So that concludes our portion of the presentation. Are there any questions, things we can expand upon, answer more for you all?
As folks are working on getting any questions or comments in the chat, one question that is commonly asked, or comments that I hear a lot are, y'all talk a lot about language, and this is something that's not like something I do every day. This is new for me. I'm afraid I'm going to mess up. This gives me too much anxiety, and I would say that's, it's a normal response. And I would also say that the concept of cultural competence that many of us have been taught teach us that we need to be competent and then go in there being competent. And I think that's less helpful for work a lot of times with cultures that you're not very familiar with. And the concept of cultural humility is most helpful. So going in there with an air of humility about you, being like, I learned, that there may be some words that I use that may not feel right for you, and I want to know about that. And and I'm learning, so you let me know, and be curious and ask questions, in that way that shows that the patient is the expert in their own experience and you are there to support them with their experience. And so I find that, once you just kind of go in there with more of a humble manner about yourself, it usually goes really well. Patients take a deep breath, like, okay, this person is willing to at least listen to me. And that can go a long way.
Along with that, something that I not uncommonly hear is that people are concerned that if we're sensitive to individuals who don't wish for us to use gendered language, that we can never use gendered language. And that's not true either. We don't focus on people who do want to use the words mother and breastfeeding and wear pink flowery maternity clothes, but that is just as an acceptable experience as the one in which we've been focusing for the past 45 minutes. It's just that is the norm, and we want to create thought that whatever term we use and whatever term we don't use, we do so in a purposeful manner. And the more you're mindful of this, the more it will become obvious. I was working on some lactation related documents yesterday. And for me as a person, I do identify with the term mother and breast for my own experience. But when I was reading this document, it was making me squirm and cringe because it was so gendered. And I was able to recognize that this would be triggering for a different individual, even though it pertained to me in an applicable way. And I think that's an important distinction to make.
Affirmation for all.
Do we have anybody who wants to comment, or if anybody has any questions? I don't see anything in the chat, except I have put in the link for our feedback that we can provide y'all later on. But if anybody has even any comments, please feel free to unmute or to put those in the chat box.
Question for y'all. Have any of y'all had gender diverse or trans, non-binary, intersex patients come through in terms of the pregnancy or postpartum routes for y'all?
No, I haven't.
I haven't either.
Oh, go ahead.
We have a question in the chat regarding how many patients we encounter on a yearly basis. I'm guessing the question is more in terms of obstetrical patients. Colt or Natalie, do you know how many patients our gender clinic just in general is serving in a year? It's a whole lot.
And I will admit my numbers are probably skewed compared to many of our family doctors because this is a special interest of mine. And so I'm listed on the GLMA as someone who is open to taking care of these individuals that I do training. It's on my biography that you can find externally. I have a lot of patients who find me that way, or they say, I heard from a friend that this is a safe space for me to get care, or we have a specific transgender intersex specialty care clinic that's comprehensive with endocrinology, behavioral health, plastic surgery, gynecology, et cetera. And I am one of their people, one of their primary care providers that they refer to, because these are patients who have hypertension, they have diabetes, they have other problems just as the rest of our patients do. And so we need to care for them as well. And I'm certainly, we're trying to work with our department to expand the knowledge of family docs. I graduated residency 5 years ago, and this was not touched on at all when I was in residency. So it's definitely a topic that needs more attention. And I think we've given this presentation and similar presentations several times. I always say that for every one time we speak, we get invited to speak 2 more times because people are so interested and want to learn about this.
In terms of numbers, the transgender clinic with Mayo Clinic has a whole lot of patients. Like Natalie, I am trying to do some math in the top of my head, just in general, my patient panel, I would say probably almost 5% of my patients are gender diverse. In terms of obstetrics, it's a much lower number. And I probably see all of the transgender individuals interested in lactation at Mayo these days. And I would say there's, anywhere between 1 and 3 a year that I'm touching base with.
So we have another question in the chat about how do you support families who don't want their newborns to have a sex assigned at birth due to their own historical experiences and or desire to let the child self-determine. I'm going to let Dr. Sanamon take this one because I know this has been one of his passion projects in residency.
Yes, and I do hope to get pregnant one day, and this is a goal of mine, is to not have my child assigned a sex. And I think a goal is to not have a baby in Texas because legally they, assign a sex, usually female or male, unless there's a blend of genitalia where it's not very clear. Then I think you can do something different. So here in Minnesota, there's an option for unknown or X. And I talked to, so the answer is you got to talk to the systems that are in place. So wherever your birth center is, learn who are the people that are making the documents. Go to them because they'll know what they can do legally. If they don't know the answer, they can talk to their supervisor who can find the answer. So that's the first thing I did. Our health unit coordinators, we call them HUCs. I went to the HUC because they have the power of the paper. And they usually, just kind of put in all the information that's in the EPIC or that somebody has communicated to them. And so my job is to talk to whoever's going to be my birth people, right? Or if I have a patient who this is their experience, is to make sure that everybody's on the same page with the patient's desires and see what of them we can accomplish. Again, ethically, legally, with all of those things. The other piece is they might not want anybody to see their child's genitals. And so we have to figure out what is the minimum number of people that can, appropriately. So like our pediatrics team or family medicine team, whoever's going to go in and do the initial infant exam, I think that would be an appropriate group of folks. But then, that may be it. And if they're changing the baby's diapers, they don't want the nurse to see or whatnot, I think that's still appropriate. And so just figuring out what in your systems and with your groups is possible, and speaking with each of those groups and helping them understand why this is so important, and also unifying. I find when we go in and remind everybody of things that we already know, like we're all here to have people have great experiences or really positive experiences. This patient has let us know that this behavior leads to a negative experience for them. And so we want to avoid that. So if you can kind of break it down there and keep everybody on the same page, people might freak out later and have their own, oh my gosh, this is so ridiculous. And people can have their own opinions. That's fine. But we need to keep them away from the patients so that the patients can have that positive experience. And so, yeah, so if you need to talk to your legal or ethics department or things like that, it's just important to kind of have as many different conversations with as many different systems and groups in order to see what is possible. And then from there, communicate that to your patients. And in San Antonio, I think it's really important, if y'all want to really pursue providing safe space for trans people in pregnancy care, SAGA is the group there, San Antonio Gender Association, or SAGA. They're very active, and they just need to know where to send people, because a lot of times communities are like, I don't really know. But if this is something that may be a passion project for somebody or a couple of people in your institution, I'm happy to connect y'all with SAGA. I think that would be very helpful.
And as the physicians in this case, it's important to recognize that it's okay if you don't know everything, but to recognize who your care team is. And if you have questions about the birth certificate, just like with any other patient who had questions about the birth certificate, you get your social services team involved. If you have questions about the process, you would get your health unit coordinators involved. And so just to be thoughtful about how you can support this family, even if that means that you don't know everything, but you know how to find the resources that they need. In terms of the actions that we can take in the delivery process, in the case that a family doesn't want their infant's genitals announced, all you have to do is not announce what type of genitals are on that baby when it is delivered. So just being thoughtful that you stray from perhaps your standard practice, if that is your standard practice, and also that you are the leader as the physician on that team, and make sure that your nurse and your medical student and your nursing student and whoever else is in that room also announce, yay, it's a healthy baby, instead of announcing the anatomic genitals that are present. And it's a very easy thing to do, just to be the leader on that team and support that parent's preferences. I'm sure you have all seen and heard birth plans and birth stories, and how important a time period this is in most individuals who bear a child's life. And for the most part, it's the little things that we do that make the biggest difference, because we have no doubt that you can provide excellent obstetrical care. It's the things that we do beyond the textbooks that sometimes make the biggest difference in their experiences. And as family doctors in the clinic, recognizing these things both before and after the actual delivery care.
I think it's also important to remember that these patients are in your practice already. You just might not know it. Since I've become more prominent in taking care of gender diverse and queer individuals, I've had so many of my own patients message me and say, hey, I would really like to talk to you about this, and I've been nervous, and I was really excited to find out that this is something that you do, because I didn't know where to start. Or you might have colleagues who say, I just got a message from a patient because they didn't want to tell me in person that they feel different than what they were born. So these patients are in your practice already. And so being welcoming to them when they're ready to tell you.
I just went ahead and put the information for SAGA, the San Antonio Gender Association, so that, again, if anyone wants to reach out, if they feel like they want to be supportive or they'd like to see more of these patients, then you can get in contact with the community leaders.
I also want to point out that we're all works in progress. The three of us are very passionate about this, and overall we have excellent institutional support. However, we still have pink and blue bassinet cards, and we still have hats with bows on it, and we still have a Department of Maternal Fetal Medicine. And so these changes don't all occur overnight, but at least we're becoming more aware and making incremental changes over time. And the first step of that is being thoughtful and aware, because you can't make change until you're aware of what the status quo is. Any other questions or points of discussion? I'm sure the three of us could chat about this all day, and we have managed to ask ourselves questions over and over, and we can continue to do so. But if there are any points you'd like us to chat about, we'd be happy to.
Ryan, you're absolutely correct that pink used to be the boy color. Blue used to be the girl color. It was specifically through Catholicism with Mary, the Virgin Mary being blue, her color. And so that was the female color. And then pink was more like the blood of Jesus, those sorts of, and that was more the male color as well. So I think you're pointing out an important point that gender norms are not a bedrock. They actually shift over time and in different cultures. And so sometimes people think that, oh, pink is the girl color, and they will die with that idea. But it's actually not true. It's not a bedrock. These things change over time. And as you've seen, high heels in this country, post-colonization, were first worn by the presidents of the United States. So men very much wore high heels, and that wasn't seen as this drag or, oh my goodness, different type of a thing. So that's a really good point, is that a lot of people's ideas of what is gendered is specific to the time and the culture and the geographic location that they're living in.
Well, if anyone thinks of additional questions or would like to reach out to us, these are our email addresses, so please feel free, and we'd be happy to chat more.
Thank you all for a wonderful presentation today, and I will be sending out the link to provide feedback. I'll also include the email. I'll include your guys' emails address if that's okay
Absolutely.
for everybody. But thank you again so much. Wonderful points that were discussed today, and thank you to the audience for joining us as well. Hope everybody has a great day.
Thank you.